Hello, and thank you for joining us today for Psychosocial Distress Screening, a process of care, not a point in time. My name is Elizabeth Reed, and I am the Project Manager of Healthcare Professional Education at the GW Cancer Institute. Before we get started, I would like to take a few minutes to go over housekeeping remarks. We ask everyone to keep their phones on mute to avoid any background noise and disruption during the program. Due to the large audience size, we will utilize the Q&A feature for this webinar. You will see the Q&A box at the bottom right hand of your screen. If at any time during the presentation you have a question, please type it in and we will address it during the Q&A portion at the end of the webinar. The questions are anonymous and I will repeat the question. We will take questions at the end of the presentation, but feel free to write questions in the Q&A box as we go, and we'll be sure to answer them during the time allotted. To reduce background noise and enhance communication quality, we will utilize this feature for all questions during the webinar. I would like to take a moment to review today's agenda. Ann Willis will provide an overview of the Center for the Advancement of Cancer Survivorship, Navigation, and Policy, followed by Lynne Padgett from the National Cancer Institute presenting on psychosocial distress screening. We will wrap up the webinar with some Q&A from the participants. Reminder that due to the large audience today, we will take Q&A through the Q&A feature on your screen. I would now like to introduce Ann Willis. Ann is the Director of the Division of Cancer Survivorship, Navigation, and Policy, as well as the Director of the Division of Cancer Survivorship at the GW Cancer Institute. Ann brings her experience as a long-term Ewing sarcoma survivor, keeping the work of the center grounded in a patient-centered approach. Prior to joining GWCI, Ann was the Director of Survivorship Programs for the National Coalition for Cancer Survivorship. I would now like to turn it over to Ann.
Great, thank you, Liz. Before we get started, I wanted to provide you with a brief overview of our Center for the Advancement of Cancer Survivorship, Navigation, and Policy, which brings you today's webinar. The center, which we affectionately call CA-SNAP, was created in 2009 through a generous grant from the Pfizer Global Health Partnerships Program. The mission of the center is to advance cancer survivorship and patient navigation efforts locally and nationally through education and training, policy analysis, outreach, and research. The center offers survivorship and navigation resources that are available online at our website and through a monthly e-newsletter. Additional material is sent through the CA-SNAP listserv to over 2,000 subscribers, and CA-SNAP staff write white papers, create case studies, and work cooperatively with other healthcare organizations to advance patient-centered care. We have policy papers on our website to educate patients and the public about the impact of the Affordable Care Act on cancer patients and families. And we also share summaries of meetings and roundtables that we've hosted to catalyze patient navigation, cancer survivorship, and patient-centered care initiatives. The center is best known for our signature training. The Executive Training on Navigation and Survivorship, Finding Your Patient Focus, is a 2-day training program that equips healthcare professionals with the tools needed to launch and sustain navigation and survivorship programs. Participants learn strategic planning techniques for developing, implementing, evaluating, and sustaining these programs. And since 2010, we've trained over 250 healthcare professionals, and we were recently awarded funding from the Centers for Disease Control and Prevention to provide technical assistance and support to comprehensive cancer control programs. So as part of that project, we'll be transitioning the in-person training to an online format that will be available at no cost. And we will also be developing other new online training programs to enhance cancer control activities across the country. Today's webinar is part of the CA-SNAP monthly webinar series that we launched in April 2013. We feature a variety of topics related to navigation and survivorship based on feedback from healthcare professionals across the country. And we also have several research initiatives that we provide updates on through CA-SNAP. The first 3 bullets on the slide are national surveys we conducted in 2013. We have archived webinars available on our website for viewing for the best practices in navigation and survivorship survey and the social media survey, and we will have an upcoming webinar on our survivorship education findings. Our Evaluating Cancer Survivorship Care Models project is an exciting project funded by the Patient-Centered Outcomes Research Institute. We will be comparing the effectiveness of survivorship care models on patient-centered outcomes. And there are multiple components of the project that will inform the field of survivorship, and we're posting updates about the project on our website in the research section. And then one other research project that we plan to report the results on is our Patient Navigator Competencies Project. We are working with several organizations to establish competencies for patient navigators who are sometimes referred to as lay navigators. And we will provide updates on the project as it continues this spring. So we have many research initiatives at GWCI to inform the cancer community of progress and participation opportunities in our monthly CASNAP e-newsletter. Our goal is to share the findings of the work that we're doing so we can provide you with information to help you provide patient-centered care. So if there are any topics you would like to know more about, please let us know. And again, the email address is casnp@gwu.edu. So today's webinar is focused on psychosocial distress, which has received increased attention over the past several years. In 2007, the Institute of Medicine released a report titled Cancer Care for the Whole Patient, Meeting Psychosocial Health Needs. As the title suggests, the report clearly spells out the need to better address cancer patients and survivors' psychosocial health needs. Another driver behind the increased attention is a new care standard established by the Commission on Cancer as part of its new Continuum of Care Services standards that will be phased in starting next year. The Commission on Cancer is a body that accredits cancer programs across the country, and it's accredited nearly 1,500 institutions, and those institutions provide care for about 71% of newly diagnosed patients. So this new care standard has the potential to significantly impact care. Although many healthcare providers agree on the need to address psychosocial issues, meeting the standard may be challenging. We often hear from our trainees and others that we talk with that they struggle with creating a psychosocial distress screening policy. So to help you think about improving psychosocial care, we've invited Lynne Padgett to provide some information on distress, describe the COC standard and its components, and to talk about strategies and lessons learned for implementing distress screening. Dr. Padgett received her PhD in counseling psychology from the University of Memphis after completing her MS and education specialist in community counseling from Georgia State University. She completed predoctoral clinical training at the Veterans Administration Medical Center in Memphis with a concentration in medical psychology. Dr. Padgett subsequently completed a fellowship in pediatric rehabilitation psychology at the Emory University School of Medicine, Department of Psychiatry and Behavioral Sciences. Dr. Padgett's background includes research, teaching and clinical practice, and most recently at a large integrated care organization. Her interests include cancer survivorship, particularly the cognitive effects of cancer and cancer treatment, and palliative care. She also has interest in dissemination and translation of clinical research findings into community settings. So we are so excited to have Lynne speaking with us today, and we know you will enjoy her presentation. So Lynne, I will turn it over to you now.
Thank you. Thanks so much. And I'm delighted to have the opportunity to speak to you. And I imagine after that introduction, some of you are thinking Dr. Padgett also has some difficulty making up her mind as to what areas that she's interested in. So I am delighted to be able to talk about psychosocial distress to you. One of my passions in this area is not to think that psychosocial care happens when we hand out a screener and get an answer back, but rather to start to think about it as a process of care, much like we follow screening for breast cancer or colon cancer all the way through the treatment trajectory. We're going to kind of use that conceptualization to talk about psychosocial distress. One of the things I like to tell people at the beginning is that I talk a little fast sometimes, so I'm going to try and speak a little slower and to go ahead and answer the question that sometimes is floating in people's minds right about now, which is I'm a native of Georgia. So that explains why I sometimes get 3 syllables out of 1 vowel. So I hope that I'll be able to make myself clear and understand. I want to tell you just a little bit more about my background. I have tried to implement psychosocial distress screening, sometimes successfully and sometimes not successfully. I have tried it in outpatient settings. My most successful place occurred in an inpatient cancer unit where we implemented a screening protocol for psychosocial distress for all new diagnoses under 50 years of age, and we prioritized people who came in perhaps for some sort of symptom and then wound up getting an unexpected cancer diagnosis. I have had the privilege over the past almost 3 years to work with the NCI Community Cancer Centers program. One of the goals of those 21 centers across the U.S. is that they, as part of their contracts with NCI, had to implement and expand psychosocial services, and that included distress screening and detection across their community cancer center sites. And then lastly, I'm a program director, which is a title that's kind of confusing because it doesn't really describe what I do. But for NCI, I hold a portfolio of research. So I work with investigators who are looking at psychosocial distress screening as well as some other areas of cancer that I'm interested in. So again, I'm delighted to be here. So let's get rolling and see what we can find out. I will refer to the cancer care continuum several times because, as I said, this is a process of care, and sometimes it's talked about psychosocial needs at diagnosis or end of life or survivorship, but my bias is that to be done effectively, we have to think about psychosocial needs and psychosocial care across the cancer care continuum. So from prevention and detection, treatment, survivorship, all the way to end of life. So let's talk a little bit, just if you work with cancer patients, I'm sure you're familiar with this list of chronic effects of cancer treatment. They can happen in broad areas. There are physical symptoms, psychosocial symptoms, and of course economic effects of cancer treatment. And they can run the gamut from sexual impairment or, and incontinence all the way to depression and anxiety to health and life insurance problems. And of this entire list, what we know is that psychosocial distress exacerbates many of these. So if you think about fatigue as an example, someone who has high levels of distress or depression or anxiety, it often worsens or complicates their fatigue. People who feel locked into their jobs or experiencing severe financial burdens may also find that that causes elevated distress or fatigue. So psychosocial distress really kind of works its way into a lot of different areas, not just classic diagnoses like depression or anxiety. So let's start by talking a little bit about what is distress. The Comprehensive Cancer Center Network many years ago, about 10 or 15 years ago, came up with a definition. And their definition of distress is that it's a multifaceted, unpleasant emotional experience of psychological, which can include cognitive, behavioral, or emotional, social, might be spiritual in nature, and that it interferes with a person's ability to cope with cancer, symptoms of cancer, or its treatment. So two important things about this definition that I think play into how we think about assessing for distress are that NCCN designed the guidelines to be broad, so they wanted them to be wide and encompass a lot of different symptoms, and they also wanted to use a term like distress that lowered stigma, so a term that did not have a diagnosis associated with it. So now that we've defined distress, we know that the NCCN says that it exists on a continuum. So if distress symptoms can exist on a continuum, they can be anything from what we would call normative responses or typical responses to disabling responses that might have an official diagnosis or a lot larger impact on quality of life. So one of the things that sometimes patients hear when they express that they're having some distress associated with cancer is that for a long time the medical community responded by saying, well, of course you're upset, you have cancer, which is not the best way to assess distress. So that's one of the things. So let's remember that it's broad, it was conceptualized to reduce stigma, and that its intensity can vary. Now, those are good things for the definition in terms of dissemination and getting it out to the public and letting people know what it means. But when we start trying to implement distress screening and detection, This broad definition presents us with some challenges. In a medical environment where words like screening or staging of cancer have specific and precise definitions, the word distress is multidimensional. Of course, it went across multiple domains. It has a varying course, meaning, it can pop up high and then the next visit it might be low. Distress can resolve without treatment. We're not quite sure how to measure it. We're not quite sure what we measure, and we're not quite sure where to send the patients that report high levels of distress. So our definition that was started to reach out and to normalize patient experience has also presented some challenges as we begin to incorporate it into cancer care. So some guidelines have come up, and the guidelines can be very, very helpful. Anne mentioned these in the beginning. NCCN, when they came out with the definition, recommended that all patients be routinely screened. They want to find out the level and source of their distress. They said that it needs to happen at all stages of disease across the cancer care continuum. The IOM report that Anne mentioned, of course, talked about the importance of screening patients for psychosocial distress, psychosocial health, and that being a first step in their care. So what these guidelines have told us is that we need to integrate psychosocial care and assessment into regular cancer care. We need to figure out what patients' distress level is. We need to figure out what the source of that distress is. Is it cancer-related or not? We need to figure out where we need to figure out a way to provide these services across the care continuum. And we need to realize that detecting distress or screening for distress is really only a first step or a part of whole patient care. Now, we moved in 2012 from reports and guidelines to actual accreditation standards. So like new accreditation standards, we often celebrate that our area of interest has risen to the level of respect and importance that now it's a required part of an accreditation process, like from the Commission on Cancer. But also accreditation suddenly means we've got to figure out a way to do it and to count it. And so the purpose of the standard that COC put in place was to incorporate and develop a process of screening and to get this into standard care so that the vast majority of patients would receive it, and to provide these patients who have distress with resources or referrals for their needs. As I like to say, this is a worthwhile goal, and the goal was not to tie up lots of resources into an area that's poorly reimbursed, which is something that a question that was put forth to me one time. Psychosocial services, as we know, often have trouble being reimbursed at all, and when they are reimbursed reimbursed at low levels, but rather, so it's not to tie up a lot of resources in that, but rather to figure out a way to assess psychosocial needs and manage them and get this integrated into standard care. This, of course, elicited a variety of responses from people, and I have some of my favorites on the next one. So these are all direct quotes. I didn't make these up, but various questions or comments that I've received when I've gone around and talked about the Commission on Cancer Standards are, the first one is my favorite. We have a referral process. When you cry a lot or make dumb decisions, we call psych. And I think we can all agree that it's a referral process, perhaps not the most effective one, and perhaps not the one that leaves our patients feeling like they could talk to us. Some places have mentioned that they're worried about screening for distress because they don't have the resources if something is really wrong. Some places have mentioned that their social work staff is already overbooked. And one question that I have gotten several times is there a research base to support distress screening and to support this accreditation standard? The short answer is no. So we'll talk a little bit more about that. But as you can see, these new accreditation standards have quite likely elevated a lot of your and your cancer center distress levels. So let's talk a little bit about what we do know about distress and what some of the research does say. We know that there are points of increased vulnerability to patient distress. So, and that the typical course looks kind of like this really simple graphic that I made. Diagnosis, when treatment's initiated, when treatment ends, when there's no evidence of disease, recurrence or progression. As you can see, these points go around the cancer care continuum. And for a lot of patients, a common pattern is that at each of these transition points, there's elevated distress because something new is happening. That new thing may be success in that there's no evidence of disease, or it may be disappointing news in that there's been a recurrence or a progression or a lack of response to treatment. But there's some sort of transition in place, and that tends to be a point of increased vulnerability to distress. With most patients, what we see is that their distress increases and then it resolves over time. We know that that's not true for every patient, but using this continuum sort of informed the thinking of the Commission on Cancer's idea of screening for distress at a pivotal medical visit. So when you finish chemotherapy and are transitioned to radiation, that's a transition point, that's a pivotal medical visit, or when you transition from end of treatment to survivorship. Those are all things that COC thought would meet criteria as a pivotal medical visit, and those are all times that are transition points for patients where they may have more distress. So now that we know when distress can occur, or some possible common occurrences of it, what does the research say about distress? Well, as we mentioned, distress is very, very broad. So if we kind of narrow the lens into psychosocial distress, which is what the COC talked about, we have some fairly recent studies. These all came out, both of these came out last year. The first study by Alex Mitchell was in the Lancet, and it looked at survivors and their spouses 2 years after they had finished treatment. And what they found is that anxiety rather than depression was more likely to be a problem in cancer survivors and their spouses. Depression was sometimes treated, sometimes it resolved on its own, but 2 years post-treatment for both survivors and their spouse, anxiety was actually a commonly presenting issue. In another study also published in 2013, the fear of recurrence, separate from just general anxiety, was reported as one of the top concerns and the highest reported unmet needs in both cancer patients, so during treatment, and survivors. So we often think of distress as maybe being depression related. It's what I hear when I talk to people, when I see what people are screening for. But our research is starting to indicate that anxiety and fear of recurrence may actually be some long-standing unmet needs that patients are reporting, as well as their spouses or caregivers. Now, this is a little bit older study, but I think it's really, really useful. This group published in the Journal of Clinical Oncology in 2009, they assessed patients right at the end of treatment and then followed up 6 months after treatment. So they asked them to report what psychosocial needs they had that were unmet. And as you can see, these things kind of cluster around worry and anxiety and fear. So there was a fear of cancer spreading, and these percentages are how many patients reported it. Worry about other people worrying about them, so the patient worrying about their caregiver, uncertainty about the future, worry that the treatment results are beyond their control, and then a lack of energy or tiredness, so something related to fatigue. So what we see is that these problems start to show up during treatment when we've got patients coming in for treatment regularly. We've got the support of the entire oncology team there. There are still some needs that aren't being met, and that these needs continue after treatment. So subsequent to treatment, the percentages dropped a little bit. Instead of ranging from like 21 to 30%, they dropped a little. They ranged from about 17 to 26%. But as you can see, that's still somewhere between a fifth to a quarter of patients still experiencing these same needs. So as we think about this research and how it can inform us as we think about psychosocial care, the key is developing a process that spans the treatment continuum. And this is something that doesn't always get a lot of emphasis, but it's actually in the COC standards. So the Cancer Committee develops and implements a process to integrate and monitor on-site psychosocial distress screening and referral. I think it's very easy for us, whether we're in practice or administration, to go, okay, we've got to figure out how to get screening done. And that's true. That's an important step. But we also need to think about how screening fits into the process of cancer care. So one of the things I'd like to suggest is sort of taking our focus off the tree of screening and looking at the forest of psychosocial care involving 3 different areas. So if you think about this as kind of a broad and very simple model, we want to detect psychosocial stress. We want to assess it and figure out what's going on. And then we want to learn how to manage it. And this is an ongoing process with information at each of these stages interacting and affecting each level or area. So as we're managing distress, if we make a patient referral, we actually need to get that information back to the treatment team. And if they have worsening of their symptoms or if they're not responding to care, then we need to try something different to elevate that care, to make a different referral. But this all needs to be a circle of information and communication that's happening. So that, again, this becomes a process, not a single act of screening. So this is all lovely and theoretical and high in the sky, and, people are nodding along and saying yes, but the fact is, how do we do it? How do we make this happen in our care settings? I get this question a lot, or we tried this and none of our oncologists are on board. So I like to tell people, that for just 3 easy payments to me of $49.95, I will send you a cancer distress toolkit that has all the answers in it. Okay, not really. Not exactly. Sadly, we don't know exactly what would even be in that box if we could do it, and it would be unethical for me to take 3 easy payments of $49.95. So if only it were as easy to set up a psychosocial care process as it is to answer an infomercial, we'd all be in good shape. But instead, let's move along and talk actually about some things you can do at your site. My goal now is to kind of shift from what does research say, what do standards say, what do reports say, to some hands-on things that you can do in your site and some questions that you need to think about as you reevaluate what you're doing or think about what you're starting. So let's start at the beginning, a needs and resource assessment. Sometimes people want to say the beginning is the accreditation standard. How do we do this? How do we do this? And I like to sometimes slow people down and say, let's actually figure out what we have here that we can use and that works. So first of all, who wants to start screening? Who in your organization is tasked with getting it done? Who's motivated to get it done? Who wants to start it? What patient populations are most in need? And we'll talk a little bit about that when we get to some lessons learned. But a lot of times people want to start in breast because they have a breast center or a breast program. Some centers, that starts out well. Some centers have started well by starting in maybe a high need population, like perhaps brain tumors or head and neck. So again, that's something that you need to think about. But what group of your patients are most in need? It may turn out that it's not diagnosis. It may be that you choose to start with a patient population of elderly with comorbidities or Medicaid or uninsured. So again, in your system, what patients are most in need? And then what resources do you already have? It's important to consider internal and external. It's important to look outside of just psychosocial care. So it's important to look at navigation and chaplaincy and psychiatry and case management. It's also important to look at social organizations in your area. Other areas that you may find that might have an interest in helping you out with this are palliative care, rehab, behavioral health, support groups, education, nutrition, exercise, and communities. So, for example, your YMCA may have an exercise program that might be useful to you to think about. So again, you want to look at internal resources, and then you want to cast a wide, wide net for external resources so that you can start talking to the players, find out what shared interests you have, and how you can each work off each other's strengths to provide good psychosocial care across the continuum. The next question sometimes becomes, what model will you use to provide psychosocial care? There are sort of two sort of poles on this. One is collaborative care. So some centers or some offices are set up to where the psychosocial service works with oncology, but is sort of a separate into themselves. They may have different leadership. They may report to different administrators. Their funding may come out of a different area. And they work together with oncology, but they're not fully integrated, which would be the other side of care, which is where psychosocial services are operating within and as a part of oncology. So, for example, in collaborative care, if a patient presents to the oncologist and says, I am very distressed, or I'm depressed, or I'm weeping, or I want to quit treatment, or, my insurance has bailed on me, whatever. In a collaborative care model, the oncologist may go, okay, here I want you to see our social worker or this social worker, and I'm going to send you over to them. And then the social worker may send a report back on a sort of a consultation basis. In an integrative care program, psychosocial providers may be attending tumor boards, they may be giving input, they may have already reviewed the patient file and said, this patient's we flagged this as being a high risk because they have insurer problems or they have a stage 4 initial diagnosis. And so that the communication and the work is a little more centralized. In the real world, hybrid models generally tend to exist, where maybe this group is collaborative, so maybe social work is integrated, but psychiatry is collaborative and done on a consult basis. So again, just look at your group and see what works and think about where communication and exchange of information works and how that will need to happen as you start gathering psychosocial information. Now, a few lessons learned from my work with the NCI Community Cancer Centers program. The first one is that breast isn't always best. Our programs were required contractually to expand their psychosocial services and begin implementing screening. I would say 95% of them started in their breast center. And what we found, again, is that the breast center wasn't always the easiest place to integrate screening. Sometimes it looked good because there were a lot of patients, but it didn't always necessarily have referral patterns or oncology buy-in or an EHR. It just didn't always have it. So you don't always have to start with the place that looks like the biggest. What are some other things you can consider? I will tell you that it's easier to start where people are happy to see you. So if you're starting in a clinic where every time you go over, they're like, oh, dear God, are you here to have us talk to us about distress screening again? We don't have time to do that. That may not be your optimal place to start. You may want to reconsider it. For other reasons, you may have to start there, but if you have some options, it's reasonable to do it. So if there's a group that comes to you or that's happy to see you, I'm going to be honest, I've never had anyone pour me champagne and say, Lynn, psychologist, we're so happy to see you here. But where there's some more excitement, one of our sites, their GynOnc program actually is where they started because their GynOnc people and staff and nursing and oncologists were finding a lot of sexual trauma history. And it was complicating how they talked to their patients, how their patients were responding. So that's where they started it. So again, start where people are happy to see you. And it's also easier to start in areas where high levels of patient distress exist. So that particular GynOnc clinic, there was a lot of sexual trauma. So there was a lot of sort of secondary trauma or PTSD that was happening. Another place where we've had some success that's a little bit atypical is in head and neck patients. It's known that with head and neck cancers, that patients have a lot of quality of life issues, a lot of distress, a lot of functional limitations. And that may be a place to start. And the last lesson learned that I have for you is to pilot. Start somewhere. Give it 6 weeks, 12 weeks, whatever works for your program. Stop. Get all your players back. Get feedback. What worked? What took too long? What, barriers are we running into? Are you getting the information you need from this? How is this working? Okay, now let's tweak it. Let's try it here, and now we're going to expand it to RADOC. So it's important to pilot so that you can get the kinks worked out ahead of time, and so that also you can build on the enthusiasm of hopefully the people who were happy to see you when you got there. So let's talk a little bit more specifically now that you've sort of looked around and assessed your internal and external needs and figured out what resources you have. Let's look at that sort of first cogwheel, distress detection, the big picture. What are you going to be looking for in your site? Are you going to screen for distress, the broad global concept? Are you going to look for depression, for anxiety, for unmet needs? Are you going to ask about symptoms and side effects of treatment? Barry Boltz, who's a Canadian researcher and involved with the Canadian healthcare system, is a huge proponent of saying if you're going to do distress screening, you may as well go ahead and ask about things like pain and nausea, because at least then you know it's being asked. So is there a way to incorporate whichever domain you're looking for into an assessment that's already done for symptoms and side effects, or do you want to integrate those into your distress assessment? I've worked with one site who has incorporated smoking information, smoking history and current practice or usage as part of their distress detection. So again, it pays to think creative and to figure out what works best and what the people in your site are interested in knowing. How do you incorporate this information into workflow and records? People, in general, what I hear is this can't be done without an EHR. You cannot do this without an electronic medical record, and I would just say that it can be done. I know sites that do it, and having an EHR, while it may be easier to incorporate the measure, it doesn't always ensure communication, and communication is the key for making this work. How often do you want to administer it? What are the cutoffs? Are you going to use, if you're using the distress thermometer, are you going to use a 4? Are you going to use a 6? What are your cutoffs going to be? And once you have patients who score above the cutoff, where do you go from there, and how do you triage them? So that's that first big picture look at distress detection. These are some things that you're going to want to think about. Once you hit the triage point, you're going to move to assessment. So you need to figure out how to follow up on elevated scores. You may need a detailed picture. You may find out, this may be where you choose to do a psychosocial history to find out if someone has a history of an anxiety disorder or some current psychiatric diagnosis, cognitive impairment. So this is where you pick up more information to get a broader picture. You may find out at this point that a person actually is expressing distress, but that it's not cancer related. So these are some things, this is sort of getting more details and digging down deeper. You may choose at this stage to screen for specific disorders like depression or anxiety. Again, you need to think about, especially if it's diagnostic information, how are you going to share this information? How are these results going to be triaged? If you're assessing for suicidality and someone answers positively, what are you going to do? What kind of follow-ups are there? What level of care is appropriate? Should licensed clinical social workers be doing this? Should patients with elevated scores get a full clinical interview? There are not solid answers to that. We don't have a research base for it. And so you need to figure out what's going to work in your system with your patients. And it may vary a little bit by clinic, and it may vary a little bit in an office versus a cancer center setting. But these are all things that you need to think about as you're refining or implementing your process. And so let's think about how we address the patient needs. We've talked a lot about the process of what the center does or the practitioner does. But how do we address patient needs? How do I continue to monitor a patient and protect confidentiality? for those of you who have been trained in behavioral health, where the idea of privilege, not really privilege, but confidentiality is much more narrowly defined than sometimes it is in a medical environment, this can promote some tension. So how do I, as a psychologist, continue to check in on a patient but still provide confidentiality, perhaps about therapeutic issues that we've been discussing? Is the current level of care appropriate? We've referred this patient out. We've prescribed an antidepressant. Are they responding? Does it look like they're doing okay? Does it look like we need maybe a more intensive intervention? Do they need to be seeing a social worker every time they come in? How do providers communicate and share information? Navigators, chemo nurses, techs, and oncologists often hear different pieces than the psychosocial team does. And the psychosocial team often hears different pieces of information from patients than the medical team does. So you need to figure out how you're going to communicate and share that information. Who is watching out for the patient? This is key when we think about distress management and as a process. A lot of times it's easy to make the referral, but when do we reassess the patient? When do we find out if they actually did follow up and see a psychiatrist? When do we find out if they did follow up on a support group or therapist? Those are important things to know. And then as we continue to watch out or take responsibility for that patient's psychosocial care, when do we reassess them? How do we find out if our interventions that we've done are working? So these are all things that you need to think about how you're going to manage. One of the specific questions that I've really started getting probably more in the last 2 years or so is, where do navigators fit into this process? And I would say that it depends. Navigation has grown, and it's really become very exciting to see how the higher level of acceptability that's there now than used to be when I started in cancer care probably a decade ago. So if you think about your team's navigators, if your navigators want to get involved, if you're a navigator and you're trying to figure this out, and what's the role of the navigator in psychosocial care, there are a couple questions you need to consider. What's the primary purpose and target of your navigation program? Is your navigation program disease-based? Is it high-risk patients? Is it focused on disparities? That may affect how you want to incorporate psychosocial needs and care into it. What experience do your navigators have? In some places, navigators are lay-trained. In some places, they're nursing or case managers. In some places, there's licensed clinical social workers. So the psychosocial experience and comfort, talking about psychosocial issues, and recognizing sort of severity of symptoms, also of your their sort of past work experience and their comfort level, and is going to impact what capabilities they have and how you're able to use that. Is navigation going to have a formal or an informal role in screening? Do you just want do you want them to administer a distress thermometer as part of their information gathering, or do you want them to just give you a heads up if somebody seems reticent or very sad? And then lastly, of course, I keep coming back to what you all know, which is, what is the process of communication of information? So those are some questions to think about as you assess the needs and capabilities and resources of your navigation team. And again, it differs from site to site and maybe from navigator to navigator. So as I have rolled through this, what you see is that you have lots of choices in front of you. This is not, you have not just a hammer, so not everything has to look like a nail. It's not a one-size-all-fits process. It's important to leverage the strength of your system. What is your system good at? What are they prioritizing? How can you leverage those strengths and those priorities to promote psychosocial care? And then to leverage the strength of your navigation team. So now that we've talked kind of about all three areas of the process, I'm just going to briefly give you some resources for tools for detecting distress. So as you think about detection and assessment, what kind of tools? Here are, again, just some quotes that I have come across in my work in this area. Everyone we know is using the distress thermometer, so that's what we decided to use. Our behavioral health team just screens for depression. What the heck is a HADS? And according to our responses, everyone is distressed. So these kind of quotes sort of illustrate sort of how people sometimes make decisions about what instrument they're going to use. And while these are not necessarily bad, if everyone in your sort of area of town is using the distress thermometer, you probably have rich information about how it works. So let's take a look at some commonly used measures and then some resources to look at measures. So the most commonly used measure is probably the distress thermometer and problem list. If you look at the literature, you can see that it's one of the complaints about it is that it is very sensitive if there are problems, but it's not specific. It's not specific to cancer-related problems, and it's not just because distress is reported doesn't always mean that it's, again, psychosocial in nature or cancer-related. So there's a problem checklist that goes with it, so you can look at that. Some other measures that have been used are the PHQ in a variety of forms. As you can see, I've got listed here the PHQ 9 or 2, which looks at depression. The 9 refers to the number of questions. Sometimes people don't want to use the shortened form, so they take out the questions about suicidality. The PHQ 4 asks 4 questions and looks at depression and anxiety. So that's a measure that some people have found quick and also assesses 2 domains. For the person who was echoing on the previous slide, what the heck is the HADS? That's the Hospital Anxiety and Depression Scale. And there's where you can get a copy of it, a link. What the HADS does is it takes away the physical symptoms that are associated with anxiety and depression that can confound diagnosis because they're also associated with treatment. So, for example, sleep problems are common with depression. Sleep problems don't mean that you have depression, though, and you might have sleep problems related to a course of steroids you've just taken or other treatment that you're getting. So the HADS is something to look at. And then lastly, a new tool is called the POST. This is a psychosocial oncology screening tool, and it combines several areas. It has a PHQ-9 built into it. It has a global rating of distress. It has patients mark symptoms they might be experiencing like fatigue or nausea. It asks patients if they're interested in having psychosocial services contact them. And it manages to do this on one side of a piece of paper and in less than, and not quite as quick as the distress thermometer, but in easily 3 to 4 minutes. So again, this is another tool that's available. Now, I've sat here and told you about 5 or 6 tools, and I sit at NCI and I talk to, 20 or 30 community sites, and I talk to investigators. So I hear a lot about tools that I didn't hear about when I was practicing at my, little cancer center hospital. So where are some places that you can get measures or find out about measures? The first one that we have listed here is PROMISE. This is an NIH program that looks at patient-reported outcomes. They have a variety of measures there, including ones for distress, depression, and anxiety. There's an article that came out of the UK that has a long list of screening instruments. And there's a project I work with called GEMDM, which stands for Grid-Enabled Measures of Distress Measurement. And we have there, if you go to the address here and then go to the specific distress measurement page, you can find a listing of measurements. If it's public domain, you can download it there. We have a couple articles that review distress measures. And then one of the unique things about the GEM website is that we actually have star ratings and comments. So, for example, someone described it as a combination of TripAdvisor and Wikipedia. It's just for distress measures. So, for example, when I first did this talk, we had 9 comments and ratings on the distress thermometer. It had a 3 out of a 5-star rating. That was its average rating. And here were some of the comments. So it was quick and easy to use. It's widely accepted and promoted. And then someone had said, well, it is quick and easy to use, but we have trouble with clinicians responding to the data, and it's frustrating for patients and it's frustrating for researchers. So one of the nice things about going to GYM is that you can see comments from psychosocial or survivorship administration, from clinicians, and from researchers. We currently have a Survey Monkey out right now through some different professional listservs. You may have seen it come across AOSW, the Oncology Social Work, or Psychosocial Oncology listservs, where we're allowing people to submit their information about different measures of distress, whether they know about them and what they think about them, in a Survey Monkey format, which is a little more easy to use than our GYM Wikipedia setup. So if you're interested in that, my email's here, and you can email me and I'll send you the survey link. That's not a problem. So we'd love to invite you to add your own examples to GYM through doing this. You can become a registered user. You could rate an instrument. We are planning some different promotional and educational opportunities through GYM that you might be interested in. So those are all possibilities, and again, ways to find out more about different instruments that you might be interested in. So I want to wind all that back up to say my encouraging message, I hope, to you is that psychosocial distress is not about screening at one point in time. It's about a process of detection, assessment, and management. And like most processes, it requires evaluation and adjustments. So thank you so much for listening as I raced through these slides. And I will hand it back over to Anne now.
Hi, Lynn. This is Liz. Thank you so much. That was a wonderful presentation. So we have about a few more minutes for some question and answer. So if folks have any questions for Lynn, please write it in the Q&A box on your screen, and we will take the questions in the order that they come. We have a first question regarding their cancer center, an inpatient unit that have implemented distress but have not coordinated with other disciplines who may deal with cancer patients. So for example, the outpatient clinic, urology, OBGYN, and so forth. Does the requirement, and I believe this is referring to the COC standards, mandate their participation, is the question. So the inclusion of other disciplines in the distress screening process.
Right. So so let me begin by giving the caveat that I'm not with COC. I've heard presentations by them and I've talked to them, so I can't speak for them. But I would say that that they accredit cancer centers, and that what you're doing at the cancer center is going to be their primary concern to you. Their concern about you and their accreditation standard. I'm sure they would never discourage you from incorporating outpatients, like you said, people who never come to the cancer center, and that may be something you want to consider or talk to some of these specialties about, but it doesn't mandate those outside clinic participations.
Thank you. We also have a question about how long it took for your program that you implemented to run smoothly.
Oh, I'm so sorry. The first time I did it, when I tried it in outpatient, it died a quick and painful death. Our reboot, I had not learned the lesson that I tried to stress to y'all of piloting and starting small. So it took about 6 months for it to shrink down to 2 clinics when we did it outpatient. And then it took about 3 to 6 months to really run smoothly. So all told, from the time we started, that was probably a year. When I implemented it on the inpatient unit, it ran much smoother because I was dealing with fewer oncologists because, again, I was part of an integrated health program, so I worked for Kaiser then. So I was only dealing with Kaiser oncologists, so it was easy to talk to them. And I had a couple of quick sort of successes, kind of patients who had a lot of stuff going on that we were able to handle quickly and make them, they interacted with the staff in a more pleasant manner, and so that that helped. But it takes a little bit, and then you have staff turnover, and you have to do all the training again. So it really, you can't just get it running smoothly and assume that's the end and your work is done. You really have to kind of keep going and celebrate all your wins.
Thank you. We have another question regarding the COC standards about if tools that don't use the term distress explicitly still meet the COC standards.
Yeah, again, I'm not speaking for COC, but as far as I can tell based on what I've read and talked to them, as long as you're looking at psychosocial domains, you're good.
Do you have a recommendation for a tool to use with the pediatric population?
Oh, I should have looked that up. No, I don't. I can get one to Ann and Liz because I do some work with some of the people who have put together the pediatric guidelines, but I can't give you one off the top of my head. I am so sorry.
Oh, no, we can certainly follow up with them after the webinar as well and include that. So we have an interesting question about do you have any experience with or recommendations for ways to indicate any financial benefits of implementing this process, such as decreased readmissions?
I don't know of any data on decreased readmission. There are some broad level articles looking at population data that, if you do a search, indicate that handling psychosocial care reduces overall medical costs because high utilizers tend to have high medical utilization. They tend to also have problems like depression and anxiety, but we don't have really cancer-specific data, unfortunately.
Thank you. That is a very interesting field to look into. So we have a few questions regarding the time in which you screen, the point in time where you screen for distress in patients, and regarding the frequency of it, in terms of screening patients too often, or they're either too acute to respond or on comfort care and not appropriate. Do you have any response?
Right. First of all, one of the issues, and I saw questions popping up, I was actually part of a hospitalist team. I was the integrated psychologist that did this, so I was not part of an oncology team when I implemented it on inpatient. And two, acuity and palliative acuity, it was just always a rule out. If they're too sick, then they need to be better. So sometimes we wound up doing it as they were leaving, which is fine because then we referred them to resources outside the hospital. So in my mind, acuity trumps assessment. Second of all, in a palliative setting, you're going to assess it differently, and you may do it interpersonally, but depression, anxiety, existential angst, and regret are common psychosocial feelings in palliative care. So the team is probably assessing it maybe a little more informally, but that's something also to think about because psychosocial care is a huge component of palliative care. In terms of frequency, that is a tough call. You don't want to do it necessarily at every weekly visit, but at the same time, you're struggling with the tension of once it's kind of implemented in your process of care, you don't want to have too many exceptions because then the process tends to fall apart. So that's why sometimes the COC, that's part of their reasoning behind the pivotal medical visit is it changes. So once you finish that 6 weeks of chemotherapy or 2 weeks of radiation at maybe the initiation and the commencement of it.
Thank you, Lynn. So we're now at the end of our time for Q&A, and I just want to mention a few GWCI CA-SNAP resources. Please check out our website that includes information on GWCI, CA-SNAP, and the programs and initiatives that were discussed on today's webinar. You can visit us on the web at www.gwcancerinstitute.org. CSNAP hosts free monthly webinars, so please join us again on February 19th for our next webinar. Following this program, you will receive an email with the recording evaluation survey to provide feedback on today's webinar, as well as the slides. Thanks again for joining us. We hope you have a pleasant day. You may disconnect at this time.